And now we will be hearing from Dr. Amy Werremeyer, also from NDSU.
Okay, that was a tough act to follow. My goodness, Natasha's my colleague here at NDSU, so familiar with her work and very proud of it. And mine is not very related, but I'm also a pharmacist, so I guess that's the relationship that we would share. Okay, so I'm going to talk about evaluation of methadone medication dispensing unit in North Dakota, but that's a little bit misleading. That's the title of my project. And it's a little bit misleading because we haven't gotten to any evaluation yet. And I'll show you more about why that is. But I want to first orient you to that this is a collaboration between NDSU's ONE program, which stands for Opioid and Naloxone Education. And that's a program housed in the pharmacy practice department here at NDSU that focuses on reduction, upstream prevention and reduction of opioid-related harms. And the collaboration also includes Community Medical Services, which is a licensed opioid treatment program. I'll talk more about those momentarily. And Dakota Drug of Stanley, North Dakota. So a collaboration across 3 entities. And the purpose of this study is to evaluate the impact of implementing a medication dispensing unit for methadone. A little bit of background. Methadone is the gold standard for the treatment of opioid use disorder, and it's been shown to reduce opioid-related fatality, reduce relapse rates, increase time remaining in treatment, reduce jail recidivism, and there's actually many more positive outcomes. The list goes on as far as how beneficial methadone can be. The challenge is that methadone can only be obtained from a licensed opioid treatment program. And SAMHSA, the Substance Abuse and Mental Health Services Administration, licenses and regulates opioid treatment programs. And it is a very extensive regulatory process to implement a licensed opioid treatment program. And North Dakota has only 4 of them, and those are represented by the boxes, the square boxes on this map. So you can see they're located only in urban areas, Fargo, Grand Forks, Minot, and Bismarck. So that's literally the only place you can go to get methadone in our state. And methadone, and the way the treatment programs are licensed are that daily administration and observed administration of methadone is required. So that means anybody who needs methadone has to drive to the licensed opioid treatment facility to get their methadone every day, at least for the first approximately 90 days. The regulations have lessened to some degree, and we have COVID to thank for that because people literally could not go to the facilities during COVID. But there's still a long way to go with those regulations. But one of the things that SAMHSA does allow is a medication dispensing unit. So that's essentially an extension of the licensed opioid treatment program that is physically distant from the hub of the main opioid treatment program location. So this could be in Oh, let me back up before I say where this could be. So we know right now in North Dakota, the data show that there are at least 20 people in Mountrail County, which is the box that's not shaded in white, but has the star around it, or it is shaded in white on your on the map. Yes, that is where there are at least 20 people who are living in Mountrail County. Sorry, I'm not explaining this well. Let me back up. So Stanley is where the pharmacy that we're working with is located. That is located in Mountrail County. And we intend to, oh goodness, there we go. Okay. So what we want to do is establish a medication dispensing unit at a community pharmacy in Stanley that is affiliated with the opioid treatment program in Minot. So we want to eliminate the need for people that are living in Stanley, those 20 people who live in Mountrail County or around that area, to have to drive to Minot to get their methadone. And we are working through the regulatory process to get to that point now. So we hope that we will have a medication dispensing unit available in Stanley within the next 12 months. So a medication dispensing unit is not a vending machine like it might sound. It is actually a facility that has the capabilities of what or at least some of the capabilities of what an opioid treatment program would have. So when we partner an opioid treatment program and a community pharmacy together, then we can get methadone available in Stanley. So we are working to do this with Community Medical Services as well as Dakota Drug in Stanley. And this is one of the SAMHSA allowed functional units for methadone medication dispensing. So these are the ways that SAMHSA allows methadone treatment to be obtained for people with opioid use disorder. We're working in that center column, working on medication dispensing unit setup. This is a lengthy regulatory process. So we have gotten to this point in time now where we are working to establish a certificate of need that is at the state level that requires extensive community support. So we've met with the Stanley Board of Commissioners. We've met with the district attorney in Montreal County. We've met with the corrections officers in Montreal County, all to obtain letters of support to indicate that this is something that they think is needed and that they would be willing to help to form a network with this program to make sure that patients have access to it, that they're aware of it, all those sorts of things. The timeline from here is somewhat uncertain. I'm sure almost all of you are aware of some of the challenges in working with federal agencies at this point in time. And so when we started this project, we were aware that there was going to be a lengthy regulatory process and that the federal agency navigation might be difficult. But that's only exponentially grown since the project began. A few things about North Dakota that make this a unique place to undertake this kind of program, which, by the way, has not been done in a community pharmacy anywhere in the country before. There is not a licensed medication dispensing unit in a community pharmacy in the country. But in North Dakota, all community pharmacies or any pharmacy has to be at least 51% owned by the pharmacist. We're the only state in the union that has that law. And so we have a unique environment of practicing pharmacists who are the owners of the places where they work. And so we have a somewhat captive audience and a lot more relationship already in place with our pharmacists across the state. And so we were able to find Stanley as a partner very quickly and continue to navigate the process of obtaining the regulatory approvals that we need with their help. These are the requirements for what a licensed medication unit needs to do. So we're also working on setting up policies and procedures so that when we get to the point of being evaluated by Substance Abuse and Mental Health Services of America, we will be ready to rock and roll with taking care of the patients the way that will require us to. So here's what we will do once we get the medication dispensing unit established. We will collect two main threads of data. One is patient level data about their access to and their adherence to methadone. This would be aim one, and we aim to enroll 20 to 25 patients who are located physically distant from Minot, who will get their methadone from the medication dispensing unit at Stanley instead of going to Minot to get their methadone on a daily basis. Those patients will remain on their already established methadone dosing schedule and formulation using the exact same protocols that the opioid treatment program in Minot has, but it will just be implemented and dispensed to them in Stanley with the pharmacist collaboration. And we will also conduct aim two, which will be a staff survey to collect information about the staff's perceptions of the medication dispensing unit. So this would be staff at the opioid treatment program, as well as the pharmacy in Stanley. So a little bit more detail about those areas of data collection. So the things we will measure about access to methadone will be driving distance to obtain methadone treatment. We'll collect this at baseline, which will be the patient's current distance from their home to Minot, North Dakota. And then we'll collect this at 30, 60, and 90 days. And that will be the distance from their home to the medication dispensing unit where they're now going to be obtaining their methadone. You might think, well, why not just collect this at the end at 90 days? But we know that some of these people have a tendency to be unstably housed. And so we want more than one data point to determine if there is indeed changing trends over the 90-day period. And then we will look at their adherence to their methadone. So we'll look at two different measures of that, which is first methadone missed doses per 30 days, as well as the TC30. And the TC30 is defined as receiving at least 75% of methadone doses and at least one dose in the last week. These are measures that are already collected for all patients that are enrolled in the opioid treatment program, but we'll have a good pre and post comparison, as well as intermittent comparison as we go through the 90-day period once the medication dispensing unit is established. As far as aim two and our staff level perception information, we will conduct a study 90 days post implementation. So once the medication dispensing unit opens, 90 days later, all the people that are involved will receive the survey. This will involve three independent measures which are associated with implementation science in community pharmacies and other kinds of services. So three different arms of this survey: the acceptability of the intervention measure, the intervention appropriateness measure, and the feasibility of the intervention measure. And these are rated on a Likert scale. We will also have 10 open-ended questions that will ask more information about the location of the medication dispensing unit, some things about the logistics, supportive factors, barriers, and lessons learned. all with the hope that we will be able to develop some best practices that can then be shared across the state for other community pharmacies to open medication dispensing units as well. Because as you may recall from looking at the map, there are lots of deserts where methadone is difficult to obtain. And there's a lot of driving going on across the state to get to the places where people can get methadone. So we hope that this is a practice that will be able to spread beyond just this initial pilot. Okay. So community medical services will be collecting this data in their medical record system, the patient level data, and they will deliver it to us in a de-identified fashion with a patient number assigned rather than any identifiable information about the patient. And that will allow us to pair the measures from baseline 30 days, 60 days, and 90 days across that time span. So we're looking at the same patient all across that length. We'll use intention to treat methodology and a p-value of less than 0.05. We'll use paired t-tests to look at within patient comparison of the driving distance as well as the missed doses per 30-day period, and a McNamar test to look at the cohort comparison of the patients meeting the criteria for the TC30 at baseline and at 90 days. As far as the descriptive summary for the survey results, we're going to look at, we'll do a descriptive summary of that perception information and try to identify any common themes that we see. And we'll be using the implementation science framework of the, I want to get the abbreviation right, so let me make sure I look at my notes in the right spot here. Consolidated framework for implementation research. That will be our kind of guiding tool for categorizing and thematically summarizing the data. Let's see, what else haven't I talked about yet? The resultant quantitative and qualitative data will illustrate action steps for implementation, feasibility, and acceptability of an MDU in a community pharmacy to inform future expansion efforts, as I already mentioned. These are a summary of those outcomes we'll be able to report at the end of 90 days. That is all I have for you. Any questions for me? Yes.
So it looks like this is a huge regulatory burden to like even get this going.
Yes.
So hopefully you can get it going. And then you already mentioned that one of your goals is to help essentially pave the way for other groups to do this.
Right.
So if you have to put in, say, 100% effort to get this done, what are you hoping like the next group, how much less effort? Like 50%, 25%? Like where do you think you're gonna sort of land for the next group?
Yeah, that's a really good question. We are keeping a journal as we go about each and every step, each and every meeting, each and every conversation we're having so that can hopefully serve as kind of that roadmap. At each community that a medication dispensing unit would be implemented, there does need to be the community engagement and support development. And at this point, that's been the most timely or time-taking task. I'm hopeful that is 50% of the overall work to get this established. I think on the back end, all of the process, the protocol sharing, the contract setup between the opioid treatment program and the community pharmacy, once we have a template for all of those things, I think that part will be very smooth to just kind of pick up and place in another location. But the community engagement and support part is what will need to be replicated in a lot more detail across different organizations and locations. Yeah, thank you. I saw her hand first.
Can you talk a bit more about the work, because I think oftentimes we want programs to help people, but then we also have the not my backyard.
Yeah. Yeah.
So what have you seen there?
That's a great question. And we went into this with a little bit of concern about how it was going to go. But we're fortunate that in the Stanley community, there has already been some groundwork and people who've gone before us have started to pave the way. One of those was that they have a drug court process that is established. And that has been one of the ways that actually the state's attorney told us that before the drug court program began, he would have been completely against this. But he has seen some of the benefits that have occurred with the clients that he has seen in that drug court. And that has really opened his eyes to the ways that we can address substance use disorders differently in non-punitive ways. And so that he actually came and spoke at the county commissioners meeting then on our behalf. So I think that as soon as you can find a couple of champions, that really helps to grease the skids, maybe you'd say, with others in the community. Yeah, good question.
So addiction and mental health are big problems across the Great Plains, the whole country. And they are a key sort of health priority across the states. And in other SCTRs, there are practice-based research networks. See any way of leveraging practice-based research networks?
Sure. Well, I would think that, so we may already be a little bit down the road to developing one, perhaps, that's specific to medication dispensing unit establishment. We ended up getting connected with a group in North Carolina and a group in Tennessee, just through kind of conversations in our professional organizations and things that are also seeking to do this same kind of thing. And so sharing best practices, lessons learned, thus to this point, has been very helpful with those groups. But in terms of practice-based research networks, I think there's a lot to explore there, but I'm less familiar with how they function, or maybe what would be the immediate go-to wins versus what would take a longer time to set up in terms of relationships and next steps.
And I think the sites that belong to it are probably still around, so it might be worthwhile reconnecting with them strategically.
Okay, thank you. I appreciate that. Yes.
Hey, great presentation. I have a totally novice question.
Okay.
So, is the methadone treatment, is that related to the needle exchange program? I'm asking because I was at a county commission forum and forums yesterday. That was the point that was mentioned, like how much people hated this program.
Sure.
How much they hated it, I really need to figure out, but this is
Yeah.
so I'm just wondering, that might be part of that, not the engagement or perhaps.
Right, right. Needle exchange programs are typically very separate from opioid treatment programs, although they may very well have the same clientele. Opioid treatment programs have very strictly established protocols. They have a medical director, a very thorough assessment process, regular drug testing that's required. Needle exchange programs are a completely harm reduction focused model where they are essentially acknowledging people are going to use drugs, and no matter how we might try to prevent them from doing that, we do better if we meet them where they're at. And so it's basically providing them a safe way to use drugs while hoping to establish relationship to eventually maybe get them into an opioid treatment program. Does that make sense? Good, yeah. And I think a lot of people's opposition to needle exchange programs is, one, it feels like you're enabling and supporting bad behavior. I don't like the term bad behavior, but and that there's debris or evidence of drug use then that ends up on streets. And but the literature shows that you get more contaminated and more quantifiably higher levels of needles in communities if you don't provide them in a safe way. So yeah. Yes.
As you probably know, but the Rural Health Transparency Program for North Dakota has that focus on pharmacists and rural communities to change prescribing capabilities. So we're just wondering if you're working with them, if that's something that you're kind of take these results and go to them.
Yeah, so working on that, I actually just had some calls with Pat Trainer this week on that exact topic. Working on submitting kind of proposal to equip the state's pharmacists to prescribe according to the new legal authority that has been given to them. This hasn't been a fold into that conversation just yet, but I'm hoping that in years 2, 3, 4, it may. I feel like we have to prove that this can work. And so we're working to do that now. Yeah, good question. Thank you.